colleague, Alex, who is giving a talk today. Alex is professor of sociology here, based within the Wellcome Center for Cultures and Environment and Health, and her research sits at the intersection of medical sociology, science and technology studies. Her research has included place and experience of older people in acute and emergency medicine, the role of digital health, and new technologies in the monitoring of chronic health conditions, new diagnostic technologies in dementia, diagnostic of dementias, and most recently, the experience of living with dementia over time. And her talk is titled Mind Matters, Sociology of Dementia Diagnosis.
Thank you so much. Thank you for that lovely introduction. I don't think I've ever been introduced so thoroughly before. So that's very nice. Thank you. Thank you for inviting me, and thank you everyone for coming. It's really a pleasure to be here actually, because I live so far away from the university. I don't get to come as much as I would like. So it's really nice to actually be here, talk about some of my work. And I'm really grateful for you taking the time to come. So yes, I'm a sociologist. I've been here at Exeter since kind of a year and last April, so a little while, but I've only really been in the department and getting to know everybody probably since September. And I'm going to talk today a little bit about an upcoming book. I promise it's not just a plug. It's the first opportunity.
Can you get rid of the Zoom thing on top of the thing? I just drag everything on the screen up.
Is that better?
Yeah, thanks.
So it's the first opportunity I've had to actually talk about some of the ideas that I've tried to develop in this book. A bit of a disclaimer, please don't judge me on this, but this book was supposed to be a very short pivot. I don't know if anybody else has written a pivot that was reflecting on my postdoctoral fellowship project that's funded by the Wellcome Trust, which finished around 2016. So clearly that didn't happen. And that was partly because some of the ideas I was thinking about and developing were kind of going beyond perhaps what a pivot could allow me to do. So partly good academic reasons, substantive reasons, but also life. Kids, COVID, a very busy first teaching role. So the book did gather dust for lots of periods of time. So I got back to it when I came here to Exeter to really finish the book up and hopefully be out in April. And I suppose when I was engaging with it, I started to realise increasingly that I was speaking to a kind of developing or burgeoning field of study in the sociology of diagnosis. But I was also really calling on kind of cross-disciplinary social science perspectives on dementia and ageing. And I wanted to try and use diagnosis as a route in. So when I first was awarded the funding for the postdoctoral fellowship, it was very focused at the time. It was a bioethics fellowship, actually, which has now changed to social science more broadly. But at that time, it was very focused on bioethics, and it was focused on kind of communication of perhaps earlier on certain diagnoses. But it very much developed outwardly from there. And I wanted to use memory clinics and the point of diagnosis as a way to engage in broader topics that extend out beyond the clinical walls of diagnosis, to think about how wider cultural representations and understandings of dementia and ageing enter into the clinic, but also how they go out into cultural understandings and perceptions of what it means to age well, and to have cognitive decline. So I guess the hook is the diagnosis, and the bulk of the work that we're talking about does come from an ethnographic study that was in two large memory clinics, one in England, one in Wales. Slightly different in their specialisms and their makeup, but on the whole, they were these secondary services to diagnose people living with some kind of cognitive decline, to try and get to the bottom of what was causing their issues with memory and thinking. But there are also, since that project finished, I've spent a lot of time doing qualitative work with people in the community who are living with dementia, about their experiences of what it means to them to live with dementia, how that shifts over time, how they engage with their environments and people around them. And that's very much been reflected back on a lot of the data they gathered in this original project. So it's kind of, I guess the main data comes from that ethnographic study, but there are lots of ideas and thinking that have developed subsequently. So a little bit of background and context. I'm sure many of you have experiences with dementia, perhaps in your own lives, with some of your relatives or friends. But I guess one thing to make clear at the start is that dementia is something different to Alzheimer's disease. So it's a set of diseases that can cause problems with memory and thinking. So Alzheimer's disease is the most common cause of dementia, alongside vascular dementia. And then there are more rare diseases that can cause dementia, things like Lewy bodies, things like specific forms of aphasia, and early onset Alzheimer's disease, which is, again, kind of more a rare form of the condition. But I think it's useful to think in a way about dementia as a kind of makeshift disease category, and that's something that Michael Hillman described it, and it's been really helpful in my own thinking. Because in terms of the kind of policy agenda, public perceptions, public awareness programs, I think quite often we think about dementia in a similar way to a disease category, because it enables people to kind of culminate in, around a kind of category that makes sense. That it can kind of help to bring about more resource, more public awareness, and it's kind of a helpful way of kind of mobilising action, I guess, around a particular problem of dementia and ageing. When I started this project, the problem of dementia was really gaining a lot of prominence in the kind of UK policy arena. So it was around the time of the first Prime Minister's challenge for dementia. It was one of Cameron's big sort of challenges, and it paved the way to the dementia national strategies. There was a kind of call to say we want memory clinics on every UK street corner. We want to expand accessing people to get early diagnosis. And this is being replicated internationally. So lots of countries, particularly Western nations in Europe and in the US, were developing their own national strategies for how we deal with dementia, in particular, and ageing. And even kind of international organisations and infrastructures, things like the World Health Organization, started to prioritise cognitive health as a major issue for international public health collaboration. So memory, this is taken from an NHS website, which is about what to expect when you go to memory clinic and what it's there to do. So it is a secondary service that you are referred to. You can self-refer to a memory clinic, and some people do. Most commonly, it's GPs will send somebody who they think that may have some issue with their memory that they want to assess by a specialist. But it can be done also by nurse practitioners or even social workers who are working with older people who think they might need to be assessed, or there's some underlying issue with their memory and thinking. So there are different routes through which to go to memory clinics. Most in the UK are run by old age psychiatrists or geriatricians. In rare occasions in the UK, you'll have them run within neurology, but that's quite unusual. That tends to happen more in the States and other countries in Europe. And they tend to run in very similar ways, in that currently the diseases that cause dementia have to be identified through a process of exclusion. So there's not a brain injury, there's not a depression or something else that might be causing people to struggle with their memory and thinking. And then it's a clinical diagnosis based on people's presentation of symptoms, things like cognitive testing, where people have to do different activities, they'll ask questions for recall, and it's bringing together all of that information. And so more recently, there's been new advances in kind of biomedical sciences and new diagnostic technologies. So there are more sophisticated forms of scanning, brain scanning, for example. And in the research arena, there are lots of different new developments in terms of identifying biomarkers, genetic susceptibility. But in the clinical context currently, it's still very much a clinical diagnosis. So I wanted to start, one of the things I was doing when I was trying to finish writing the book was that, maybe a procrastination exercise, but I was reading a lot of novels about the topic, trying to think through some of my data, and so I started the book with this because I thought it did two quite useful things. So this is a quote from, I don't know how many of you are familiar with Jennifer's book, Still Alice. It was made into a film with Julianne Moore. Maybe some of you watched the film. But so she was a very kind of high-achieving academic who ends up getting young onset Alzheimer's disease. And this is the point where she gets diagnosed. It says the sound of her name penetrated her every cell and seemed to scatter her molecules beyond the boundaries of her own skin. She watched herself from the far corner of the room. And it was a really useful starting point for me because on the one hand, it does something about representing, I think, a lot of the kind of cultural understandings about what dementia is or can do to a person, about kind of breaking apart their sense of wholeness as a person, as somehow kind of separating a sense of their identity that is somehow removed from what's happening in their material pathological body. But on the other hand, it also is really reflective of the sort of transformative power of the Diagnostic Act, which is a real theme very much embedded in medical sociology and the sociology of diagnosis. We think about things like biographical disruption, illness narratives. There's so many different kinds of, I'm thinking of Sontag's book on illness metaphor about moving into the night side of life and the kind of darkness of illness. And the description was this really kind of visceral, powerful, distinct moment. And it was a moment of a degree of kind of certainty that you could observe between moving from one state to another. And while it was really useful to think about that kind of symbolic force of what being attached with a diagnostic label can do to a person's sense of self and their ideas of their future lives, it also completely obscures the socially contingent nature of diagnostic classifications and their implications. And what I was really interested in is that actually, unlike Alice, most people that live with dementia or Alzheimer's or another form of dementia tend to be older. There isn't a distinct visceral moment of diagnosis. That's quite unusual. There are a lot of people living without diagnosis. But also, it doesn't engage with those key, I guess, sociological questions about, how do we make dementia? How do diagnoses get constructed and how do they shift over time? What are the kind of wider politics at play that shape how these boundaries shift, these categories change? And what are the implications of those things for the people being labelled with the diagnosis? So, and you're going to have to stay with me. This is a little bit of an oversimplification, but it's a useful kind of setup in how I'm trying to think about these two kind of tracks of work within the social sciences of dementia and how they might speak to one another in a useful way. So there's one kind of track, I guess, and tradition of work within the social sciences of dementia that is very much engaged with dementia experience. So it's engaging with how people subjectively experience memory loss, how that affects their social relations, how they engage with their wider environments, and even perhaps some of those structural questions about inequities in access to dementia care, or the inequalities of dementia outcomes, like who gets to get diagnosed, who gets to have access to specific dementia support. And that's kind of one track. The other track, which I guess is more leaning towards medical sociology, but particularly STS approaches, is to think about the classification of dementia. So how does dementia come into being as a category, as a diagnosis? What does it mean for people? How has it shifted over time? How does it come into being? At what moments? What are the kind of social structures that enable dementia classification to be the way it is at this moment in time? And there are challenges with each of these tracks. The first one is that it kind of takes as read as a classification to begin with. So it takes for granted perhaps what dementia is and how it's attributed to people's difficulties. And James Becker described this as a kind of neuroagnosticism. So we're not engaging directly with the neuropathology, sciences of dementia. We're engaging with the kind of lived experiences of how does it feel, how does it impact on people's sense of self over time. The dementia classification, on the other hand, can lack a kind of recognition, if you like, of how those who are affected by dementia might actually play a role in its construction, but also how that construction can play a role in their own sense of self and identity. So there's this interplay between experience and classification. And I kind of went back to some of the older works of Ian Hacking, where he really puts forward in his ideas about constitution of persons or constituting persons, of the importance of trying to bring together some of those interactionist traditions from sociology, particularly medical sociology and clinical encounters, with those systems of classification and knowledge production, so that we can see how it's important to see and understand how we can come to talk about dementia in a particular way, a particular time and place, but also how those meanings can be taken up and enrolled into people's everyday lives and understand their own sense of self and identity. So I'm going to look at each track, and I completely see how, in a way, this is a bit of a straw man setting these up as these two completely distinctive tracks. But it's useful, I think, as a way of thinking about how the clinic can be a point of where these two things can collide in important ways. So going back to the novels I was reading, this is a Rowan Coleman novel. And then this really gets to the heart, I think, of a lot of the themes that have come out, not just from me, but lots of people who are studying the kind of classification of dementia and Alzheimer's disease as a kind of disease category. And so this is somebody who's living with dementia who says, looking at my reflection in the window opposite, hollow and translucent, I see a woman disappearing. It would help if I looked like that in real life. The more the disease advanced, the more see-through I became, until eventually I would be just a wisp of a ghost. How much more convenient it would be, how much easier for everyone, including me, if my body just melted away with my mind. Then we'd all know where we were, literally and metaphysically. And I chose this to kind of set up a lot of the themes in the beginning of the book that look, I guess, at the trajectory of how biomedical sciences have been grappling, I suppose, with trying to get at the material presence of Alzheimer's disease and other diseases that cause dementia. What are the kind of biological mechanisms that we can hold on to and see and image and intervene in that connect to the symptomatic expression of dementia? And this is a problem not just for people living with dementia, as this is describing, and I think there is a kind of cultural preoccupation to some extent with understanding our own illness experiences to some extent as being somehow an outward reflection of what's happening internally. And particularly for brain and brain pathology, I think the kind of dominance, if you like, of the cultural symbolism of the brain scan and what's happening in the brain as a kind of way of explaining behaviours or how people are experiencing their thinking. But it's also a really big problem for those who are trying to intervene in, to prevent, cure, develop therapies, is trying to connect up these really varied, very disparate and multiple experiential experiences of living with dementia and what that means to people in social contexts, and connecting that to this kind of underlying pathological processes. And it's that problem, I suppose, of translation that is really being at the heart of the ongoing challenges, I suppose, of classifying and diagnosing dementia. So as I said, at the moment, at least in the UK, I know biomarkers are having much more of a role to play in private practice in the UK, but also in the US and other places. But currently, we very much rely on CT brain scans, histories, and cognitive test scores to try and identify if we think people have some kind of underlying disease causing their memory or thinking problems. There's also the ongoing challenge of dementia's association with the aging process. So we know that the age doesn't cause dementia, but it's highly associated. So the older we get, the more likely we are to experience diseases that cause dementia. And so there's an ongoing challenge, if you like, between the distinctions of the diseases that cause dementia and understanding of the biological processes of aging. So the links between pathology and the clinical manifestations of dementia are also really troubled and have been for a long time. So studies right back to the 1930s, which did big epidemiological studies of brains post-mortem, showed there were many, many people who had the signs, the classic telltale signs of Alzheimer's disease, like plaques and tangles, neurofibrillar tangles and protein plaques, which are the kind of underlying pathology of Alzheimer's disease, who showed no symptoms of dementia in their lives. And vice versa, where people's brains were completely clear that they'd shown lots of kind of dementing symptoms in their lives. So there is still a kind of ongoing challenge of connecting how and why these kind of changes to pathology can result in these kind of this symptomatic expression, and what the roots are between those two things. So they're often not the biomarkers, these markers that we identify, and often not very well or neatly aligned to symptomatic expression. And it underlines the kind of central problem to one extent between connection between brain, mind, and personhood. So when we think about the symptoms of dementia that affect memory, that affect how we navigate our environments, that affect our abilities to think and process information, that all of these are mediated through our social relationships, our home environments, so many other kind of aspects of the social cultural world. And so it becomes increasingly complex when you move through the steps between kind of neuropathology and kind of sociocultural relations. So in looking at the kind of trajectory, I suppose, of the sciences of dementia and its classification, I guess the big story to tell is it's moved from kind of associations with aging to something distinct, and that was really about developing a disease model, particularly for Alzheimer's disease. And I suppose the big way in which that happened was the development of technologies to be able to make visible these things, so to be able to actually access and visualize the plaques and tangles of Alzheimer's disease, but also increasingly as technology has developed, we can see their significance, so the density of those biological markers. But I guess the big key moment was when there was this, the distinction between what was previously called senile dementia, which was when people over a certain age were experiencing dementing symptoms, and what was seen as something separate, which was Alzheimer's disease at the time, which was only for those who were at a younger age. And in 1976, Kaplan proposed that this was a ridiculous distinction to make when they were pathologically identical. So he removed that distinction, and of course, that generated a huge upsurge in diagnostic rates for Alzheimer's disease, which, we see that replicated in lots of other things to do with kind of neurodiversity, where, when you expand what the diagnosis encompasses, and the numbers rise. I think what was really important about this movement was, in a way, part of the consequences of developing a disease model was that it was helpful in kind of mobilizing infrastructural investment, resource orientation, third sector advocacy, public awareness. If you have a kind of a disease model, you're able to kind of congregate around the tragedy of disease, and the need to kind of try and look for and advocate for cures and therapies that can treat disease. And in a way, there was a real kind of movement, I suppose, from within critical gerontology to kind of try and move away from this, what they call a wastebasket set of diagnosis, of just throwing it all in the bin of aging, rather than taking seriously how this could be a form of disease that needs to have the same kind of resource as other kinds of diseases like cancer, stroke, for example. So in establishing this kind of new disease model, rumbling underneath, particularly in the sciences of dementia, these debates and challenges over this issue of translation just continued. So you still had the replication of these large immunological brain studies. There was also greater complexity in the pathologies and pathological roots to dementia symptoms. So we're seeing, instead of very clear Alzheimer's or vascular dementia, increasingly we see that there's a mixed picture of how those different biological processes might come together to create dementing symptoms, but there's less distinction than we once thought. There's also arguments about the role that genetics play, not just in terms of genetic susceptibilities, but also the genetic environment. So if you have some people that have all the markers of Alzheimer's disease but don't show any dementing symptoms, is there something in their genetic environment that is protecting them from those changes? So there's all these debates continuing, whilst at the same time, the kind of hypothesis of the underlying pathologies creating dementia symptoms kind of still holds firm. So there's this precarity between the biological mechanisms and dementia symptoms, because of all of those studies and the kind of mixed pathologies. But most of the drug trials and therapeutics are still targeting biomarkers and kind of pathological processes. When I talked to a lot of experts who are working in the research field, they were saying that's where the smart money is, that's where we still think we're going to get the best results, that's where we're going to see real change. And interestingly, I've done some research years before where I was looking at the role of kind of new diagnostic technologies around genetics that had kind of shown so much promise and then kind of leveled off for a very, very long time. And it was a very similar kind of description about, well, actually, the hypothesis we think is we're still holding. There was no debunking or rethinking. It was very much like, actually, what we need to do is recognise that there's much more of a complex picture. We just need better research, more long-term research. We need bigger populations. We need to start earlier. It was those kinds of ways of thinking about the problem. But what was interesting in the arc, I guess, over this time period that I started to see was that the disease model started to break apart, because increasingly you started to have things like the amyloid cascade model, where it's all about actually you start to build amyloid in the brain in midlife, maybe even earlier, decades before any symptoms present themselves. And so what we really need to be looking at is cognitive health over the life course, processes of how these mechanisms develop, how they interact with one another. And so that's the kind of, I guess, the sort of ongoing hypothesis that the smart money is not just looking at biomarkers, but it's looking at biomarkers at an earlier stage. But when you start to think about things in that way, we're moving very much away from the kind of disease model. And actually, we're starting to look at pathological mechanisms that might exist across bodily systems, that might have lots of different effects as well as dementia symptoms. So this is an example of an expert who's working on inflammatory responses and how inflammation in the body might be playing a role in dementing symptoms later in life. And he really distinguished how, well, we're not studying Alzheimer's disease, we're saying you've got X going on. So if you told me you've got inflammatory rhubarb in the brain, okay, you're completely asymptomatic, but the risk is that in 50 years' time you'll have a worse ability than your peers for remembering. Take this drug and it will reduce inflammatory rhubarb from your brain. And the likelihood is that you'll not have these symptoms in 20 years' time. Am I going to take the drug? Yes. Have I ever had Alzheimer's disease? No, but I've had inflammatory rhubarb. So you're going from what you might call a functional diagnosis to identifying pathological mechanisms. And this affects whether we can have an intervention, and therefore would you like it? So there's a tension, or what I at least try to kind of bring out, I suppose, is that there's a bit of a tension between, on the one hand, the politics of anguish that congregates around a kind of diagnostic category, that you can kind of try and focus attention on curing or treating the tragedies of disease. On the other hand, you have a kind of a politics of health, which is about preventing the fear of future disease and trying to mobilize action and responses in midlife to try and prevent the challenges that may come with the development of these pathologies and how they might impact you later in life. So there's this kind of ongoing tension, and kind of both, I think both are existing in parallel. I don't know if anyone saw the campaign from the Alzheimer's Society about the multiple deaths. It got a real pushback from kind of dementia activists and people that worked with the Alzheimer's Society as kind of experiential experts. But the campaign was a son at his mother's eulogy talking about all the times that she died through the course of her later life with Alzheimer's. So she died when she forgot the recipe for the Christmas pudding, or she died when she didn't wear her usual Christmas outfit on Christmas Day. And the kind of, and that very much is about that kind of politics of anguish about, you know, and the Alzheimer's Society defended themselves by saying, well, actually, that's how we get people to engage, mobilise resources, and bring people in to making change and to get the kinds of investment we need. But I think there's also a real push, I think, increasingly towards the politics of health. Particularly, there was a kind of Lancet study in 2017 that identified, I think, 9 modifiable risk factors for dementia that was all very much orientated to lifestyle change, modelling kind of diet, exercise. There was also things about social connection, but it was very much about building towards a model of brain health. So moving away from memory clinics and developing brain health clinics, where you go in your 50s and you get kind of an MOT, and they give you, here are your kind of risk factors. You can do it now, I think. I think the Scotland one, you can go and do their tests, and you ask all the questions related to these modifiable risk factors, and they'll tell you how risky you are in terms of developing dementia and all the things you can do to try and prevent it. But it's interesting, I think, this tension. How am I for time? You have some fun.
Another 20 minutes?
Oh, okay. Everyone all right? No one's bored yet. Okay, so the second track is more about the ways in which these classifications intersect with people's sense of self and identity. Their experiences of their dementia also come into the clinic and shape processes of classification. So I went back to some of the sort of classic stuff that I'd done probably as an undergraduate, and started thinking about kind of interactionist traditions in clinical work and clinical communication. And went right back to this idea that actually diagnosis requires there to be a connection, not just between the classification of the diagnosis, but also with the presenting difficulties and challenges, that narrative provided by patients, but particularly in dementia, it requires a kind of triad because you have the carer's role becomes so much more significant because there's almost like a necessity for both the patient and the carer to kind of give voice to their experiences, to kind of witness the forgetting, if you like. And so it's a real point where these systems of classification and experience and identity collide, and both are reliant on one another in terms of holding on to any degree of kind of authority or credibility around diagnosis. So others have written about this idea of bearing witness, how particularly for diagnoses that are required for that are reliant on a kind of clinical judgment, bringing together all these different sources of evidence, if you like, the capacity of patients and families to bear witness to their experience becomes even more important because it holds quite a significant degree of weight in making sense of what's happening. And this is, I think, really apparent in a lot of the consultations that I observed in memory clinics. And I went back to thinking about some of the sort of classic interactionist ways of understanding clinical consultations and diagnoses. And I think one of the major things that clinicians are dealing with in these processes is, A, they're very much aware of what's at stake. They know the kind of emotion that comes into the clinic. They recognise the social forces and implications that a diagnostic label will have. But they're also dealing with the unpredictability of knowing how patients and families might respond to what they hear. And so they're having to deal with these contingencies in the moment. And there are lots of ways in which they do this that are grounded in social structures of social interaction. So one is about how there's a very sequenced way of going through the processes of assessment and diagnosis. The other is that there might be certain interactional modes, so spaces where there might be a kind of subjective interactional mode of experience when the patient's giving their account. There might be another where it's about a kind of evidential interactional mode, you're bringing together test results. But all of these things are kind of brought to bear by clinicians as a way to deal with that unpredictability and managing those contingencies. So things like floating an idea of what might be going on, to try and gauge responses. How have people thought about this before? How do they feel about it? Are there things they've come here specifically wanting to get? What's the context in which they're here? There's other ways of kind of enrolling patients in the evidence you provide. So in looking at things like cognitive test scores, you can kind of enroll how patients have described their experiences of forgetting into the kind of cognitive test scores to kind of say, well, actually, this aligns very much with what you're telling me, as a way to kind of enroll them into the kind of diagnostic news that you're leading towards, to kind of gain that sense of shared credibility and collaborative process through which you're kind of coming to diagnosis. And I've got an example. So this is a case where the patient themselves is not necessarily on board, I would say. And this happens quite a lot in memory clinics, where often you have very different perceptions of what's happening between the person who's being assessed, the carer, and the clinician. So, and I would say perhaps more than other kinds of conditions, there's a lot to try and navigate as a clinician in these environments. So the doctor says, oh, are you noticing that you're struggling to grasp words to describe things? No. So yeah, no, it's not noticeable in your conversation. It's just that you didn't get one of these answers. She's looking at the cognitive test scores here, and she's saying that the difficulty is about recall and remembering things after a delay. And she said, that's what you're noticing, isn't it? He said, yes. And you're saying something and then the information's gone, yes. And that's what we're noticing through the tests. So she kind of gauges that he's kind of a bit reticent about where they're leading with this. So she kind of says, kind of affirms what he's saying. Yes, you're absolutely right. It's not noticeable in conversation, but then brings him in by looking at the kind of cognitive test scores and kind of showing, well, actually, what you're telling me really aligns with what we're seeing here. And it's a way of trying to bring him in. I mean, interestingly, I'm not sure it was that successful in this case, but you can see how the kind of the floating and the enrolling is a really important way of trying to bring patients with you, particularly when information is actually often ambiguous and uncertain. One of the trends with lots of clinicians is describing that uncertainty very explicitly. You know, this is always a working diagnosis. The only way we'll ever really know is time. You know, all of those kinds of descriptions, which actually in a lot of ways are very useful and a pragmatic way of dealing with high emotion and high stakes. But there were cases, so Mr. Jones comes back and he's not convinced by this, and he proposes a different explanation. He says, this is me, but I'm lazy. And the things I should have remembered, I've remembered. But the things that come and go on, right, don't worry. It's kind of saying, it's trying to suggest that he has a degree of autonomy and control and choice about what he remembers and what he doesn't. But this isn't a pathological thing, this is just my personality, and I only remember the things that I have to. And the wife says, well, actually, his long-term memory is good. And so the doctor here has to kind of renegotiate, trying to bring back to those cognitive scores where there was a sense of agreement. And the wife kind of, she tends directly to the wife about long-term memory, saying that's very common. But she affirms this diagnosis with Mr. Jones. But I think what's really interesting is the interplay between those kind of clinical classifications and then other ways of making sense of what's happening. Like this is about laziness, and how those things might conflict and intersect in the clinical context. And one of the things that I started to think about more and more when I was doing more interviews with people who perhaps were a year, 2, 3 years into their diagnosis, was that often there's an assumption that the kind of self-presentation work and that kind of engagement in the clinical process would somehow be less for people living with Alzheimer's and dementia, that they would lack the awareness or capacity. But one of the things I saw time and again was the ways in which that sense in which you're playing a part and that you're at risk of failing to play the part in the correct way was actually heightened for lots of people living with dementia and Alzheimer's disease. And they kind of expressed it in different ways, but you'd see it in the clinic. But this man who was living with Alzheimer's disease, when I was talking to him about how things have changed, and he just came to this and said, I'm just going through a little bit of Shakespeare. It seems to be my mantra. Do you know all the world's a stage and all the men and women really players? Well, I mean, that's life. And I've learned that very impressionable time in my school life. And somehow it bubbles up surprisingly frequently. And at the beginning of his interview, I wish I had it actually, I shouldn't put it in, but that we had this brilliant exchange where he directly kind of questioned me about the interview process. He was like, well, what if I'm a liar and a rogue and I just tell you everything you want to hear? Because he was kind of questioning if I was going to talk to his wife afterwards. And he was kind of like, you know, are you checking what I've said, whether it's true? You know, maybe I'll tell you I listen to classical music all day and every day, but maybe I don't. And it was really interesting because he was so hyper-aware of how he was presenting a version of himself. And he wanted to present a version of himself where he could be a liar and a rogue, rather than someone who is lacking memory or is losing aspects of who he was. And so there was this real heightened sense of actually recognising the social necessities we all have in life to play particular roles to adhere to rules of social interaction. And I would say rather than it being reduced, for many of the people I spoke to, it was almost kind of heightened. And in thinking about classification and its impact, as well as the impact of experience on classification, Betty described frequently how she hated the word dementia, and she would only describe herself as having aphasia, about how it affects her expression, her ability to express herself, but not her ability to think. And And she felt that it was a way of demeaning her intelligence and demeaning a sense of who she is. And that started to kind of really impact on her everyday life about how the confidence she had in different kinds of social environments. I feel like I think this is my last slide. I realise I've probably gone slightly over. So coming back to where I started, with maybe the slight straw man, the 2 tracks, I think what I'm trying to say with these 2 themes is that this process of constituting people or making people up draws on, I guess, 2 competing world frames in terms of the action and interactional modes during dementia diagnosis, but also that they kind of infiltrate people's everyday lives. And one is about this tyranny of diagnosis that really does seek to locate forgetting in very specific areas of the brain, as we saw in clinical encounters, where they were literally pointing at different parts of the brain scan to say, well, this is why this is happening. And in the contrary, thinking about it in terms of socio-material relations of forgetful bodies, where you actually try to consider the ways in which memory and thinking are mediated by our social environments, our social relations, and to think perhaps more pragmatically about the role of diagnosis within those networks. And actually you saw lots of evidence of clinicians taking on that much more pragmatic way of understanding and thinking about the role of diagnosis. And I suppose, yeah, in moving between these worlds, but also navigating all that emotion about what's at stake, that actually they held on quite often to the very kinds of uncertainty that biomedical sciences of dementia are seeking to eradicate, to close down. They're opening them back up constantly as a way to kind of use temporal frames to kind of defer the object of fear to later down the line, of talking about time and needing time. We're saying this is always a working diagnosis. It tends to develop very, very slowly. So there are lots of ways in which all of those uncertainties about the underlying mechanisms are kind of closed down or seeking to kind of pin them down and closing down. The science of dementia are being very much opened up in the clinic. Thank you for bearing with me.